request Dr. Rwituja Samas to deliver her talk.
Thank you, Dr. Jayanta Das, for having me in your session. So I'll be covering the pediatric lacrimal disorders overall, but mainly the pediatric epiphora. So I'll be covering it under these broad topics. So pediatric epiphora, that is because of congenital nasolacrimal duct obstruction, usually resolves spontaneously by the first year. And the issue is basically that when the canalization of the cord starts and is usually completed at birth, but doesn't get completed actually at birth or within the first few weeks, that's when you develop the epiphora. Now, the main causes of this are a membranous block at the valve of Hasner, or a stenosis of the opening from the narrowed NLD at the inferior meatus, or the hypertrophied inferior turbinate may be a factor, and any bony abnormalities which may develop later on. So some of the symptoms and signs which we most commonly see are, of course, epiphora, discharge, and matting. But as a result of these, you may have some amount of skin maceration, and of course, the Rho+ would be positive. So in infants, there are certain other causes of epiphora, such as blepharitis or congenital entropion, and of course, foreign bodies and corneal conditions and glaucoma. But what we'll be mainly talking about is the punctal and the nasolacrimal duct causes. So on examination, you of course do a Rho+, but in children, you cannot usually do a syringing in the OPD. So you do a fluorescein dye disappearance test, wherein you instill fluorescein in the fornix, and then you can check for the disappearance after about 5 minutes to get an idea on whether it is patent or not. So when you check for dacryocystitis, you can again in younger children see issues such as these, which may be associated with some amount of respiratory issues as well. So it requires some amount of investigation before the diagnostic imaging, so it can be a confusing situation. But if you have a good anesthetist and you are in a multi-specialty setup, this would help. So up to 12 months of age, like I mentioned, you can have spontaneous resolution, but after 12 months of age, this tends to reduce rapidly, the incidence of spontaneous resolution. So we have conservative treatment and we have surgical treatment. So in conservative treatment, the Krigler massage or the hydrostatic massage, so the right way to do this would be not the way we advise. Some people I've seen advising pressing over the nose and then bringing your finger down along the nose. That doesn't really help. That's why it's called a hydrostatic massage. So exactly where the sac is located, it's important to go directly and press in that area right at the medial canthus to sort of increase the pressure in that area so any membranous obstruction can be overcome. So this is how you would advise to do a Krigler massage. You go in that area, you turn your finger, especially the little finger is used because that area is very small in children, and preferably doing it 10 to 15 times, 2 to 3 times a day. Now, when this doesn't work, the age for surgical intervention is usually after 1 year, or you could even wait for 18 to 24 months. So some of the invasive treatments, which are not too invasive, minimally invasive, I would say, is the probing with irrigation. So you can go ahead and do that with a Bowman's probe. Now, if a probing doesn't work, or if after a probing the child develops some kind of allergic rhinitis or develops the flu, that tends to get closed again relatively quickly. So you can do a repeat probing or a probing with intubation, a balloon dilatation, and of course a DCR after about 4 years of age. So when you do a probing, you look for whether there is a hard stop or a soft stop. A soft stop would indicate a canalicular, common canalicular obstruction. And usually this probing, like I mentioned, is after 12 months of age. However, people have done probing even at 10, 11, 12 years of age as well, and done it successfully when they've combined it with intubation, so that's another option. So how do you do a probing? You do a nice nasal packing. You need a meticulous technique for the passage of the probe, that is downwards, posteriorly, and laterally. And here you check for the spring test and do a confirmation of the patency. Now, it has to be, of course, done under a short general anesthesia, and the syringing is performed to check the patency. You can do a syringing which has a fluorescein stain or a betadine, so that when the suction is done, it would be visible in the suction tube. So again, downwards, backwards, and then finally laterally, so that you don't get a false passage and you confirm that you're directly in the nasolacrimal duct. So the success rate of probing, again, like the success rate of a massage or spontaneous resolution, decreases steadily with age, and the second probing has a lower success rate than the first probing. Now, after the probing, it's important that you advise topical steroid antibiotics, a nasal steroid spray like a mometasone, a good nasal decongestant, and a nasal saline, preferably for not a decongestant, but the steroid spray preferably for the next 1 month. Some of the issues which you may have is, of course, false passage and inability to actually pass the probe down. In older children, you may have a bony obstruction, so you wouldn't be able to pass the probe down. Entry into the submucosa. So where you actually want to come out is through the inferior meatus, but you may have a probe buried in the submucosa, and of course a failed probing, which of course happens in older age groups or because of any anatomical variations. Now, when there is an inferior turbinate involved, you need to do a medialization, lateralization of the inferior turbinate or a medialization together to sort of break that opening out. And this is again done under GA and a nasal packing. So you go ahead and you can go ahead and medialize it so that you can see this periosteal elevator here. So you go ahead and sort of move the inferior turbinate till you feel the click of that bone sort of cracking, and then you can widen this inferior meatus. So again, the confirmation of the patency is done in this way with the syringing. And when you need to do an intubation, there are several ways of doing it. We, of course, prefer a bicanalicular intubation, that's a Crawford or a Rittling intubation. And they have similar success rates, that is doing a mini Monoca versus a bicanalicular intubation. And this is usually reserved for when there is failed probing and along with DCR in older children. I would say do a intubation in all cases of pediatric DCR. Now, the issues that may come with intubation is difficulty in securing the passage, but if you do it under a good visualization, that is under endoscopic visualization, rather than just the metal-on-metal contact at the inferior meatus with your periosteal elevator, if you have a good visualization, you can be sure that you've reached the right area. Later on, you may have some partial or total extrusion of the tube, because keeping in mind that these are children, they may pull their tube out inadvertently. That is one of the issues which may crop up, but otherwise it has fairly good success rates if you pull out the tube after about 6 to 8 weeks. Balloon dacryoplasty is another modality in which you insert this tube. It has a balloon, and you sort of inflate the balloon for these periods of time. So that is 90 seconds, deflate, then 60 seconds, deflate, then again 90, 60. So that sort of widens this passage, and this is more effective when there is a membranous obstruction. Now, probing, again, this basically you can see the lower end of the tube. Now, it's important to have a good knowledge of the nasal anatomy when you're trying to do this endoscopic visualization. You should know where the, especially where the inferior turbinate is, and of course the middle turbinate. Now, a DCR, I'll just quickly wrap up. The DCR is for unresolved nasolacrimal duct obstruction, especially in children over 4 years, and you can go through the external or endonasal routes. It's pretty much like a minified version of an adult DCR, but you may have some landmarks which are poorly defined. So it's important to use MMC and go ahead and, of course, do a stenting. Dacryoendoscopy is a newer method which was again discussed in some of the talks that we saw yesterday, and it again has a good success rate and hardly any complications associated. However, this is not something that we are practicing at the moment. So some of the recent opinions that we've collected based on some of recent studies is that Advising sac compression for up to 1 year or 18 months of age is ideal. 2 years is probably the upper limit of advising sac compression. And it's important to use an endoscope during your primary probing, and use all 30% of people tend to use intubation even in the first case of probing. And it's better to repeat the probing, especially in a younger child, rather than going in for a DCR. So this is the overall algorithm of how to manage pediatric epiphora, and I thank you for your patient listening. I'm ready to answer questions, if any.
Thank you, Rwituja, for your excellent talk. You are rightly mentioned that we can go for what type of anesthesia generally you, for the audience I'm asking, what type of GA, there's a lots of short GA generally, what kind of advice you generally?
So basically you need a short general anesthesia with an LMA is good enough, along with of course a throat packing, because you would be doing a syringing once you identify the patency. So a short GA with a LMA is good enough, and of course the anesthesia of the nose, that is the nasal packing, is also very important. That is with lignocaine and adrenaline.
Throat packing,
yes.
Throat packing.
Yeah,
So I just want you are rightly mentioned one part that in the hardy anesthesiologist generally wants to do under a very without packing, just under ketamine. That may be very dangerous. So suppose some of your patient anesthesiologist wants to do under ketamine, straight away say no, because there is in case of an infant 11-month or 1 year, there may be a laryngeal spasm. It may be fatal. So it should be properly intubated and with a tracheostomy, with tracheal tube, endotracheal tube, with cuff. There is a term. In such scenarios, no need for any packing, no need for the gauze packing. Gauze packing also little difficult, and in a pediatric need a very soft type of gauze which may not be available. One of the disadvantages is that with endotracheal tube with cuff is little expensive one. But from pediatric point of view, for a life, one life and one child, that is a single child norm. So better we can go for that facilities, and we should instruct our anesthesiologist one. Rwituja rightly mentioned 3 points like that. We can go for a regular massage moment. If we can treat maximum number of patients, those are failed by spontaneous, then patient we can almost 90% we can treat by massage. But unfortunately, most of our ophthalmologists, even the pediatrician, they are telling that earlier our teaching was to just massage on the nose. It is not the way. Rwituja rightly mentioned it should be a hydrostatic pressure should be generated inside the sac, and it is enough to rupture that membrane.